Well, you've all you've seen this article, We Are Giving Ourselves Cancer, and this is a product of journalism. It's not peer-reviewed. We have to realize that. It is what it is. It is meant to stimulate discussion. It's meant to provoke. And that is how newspapers sell copies. And what is more interesting is to look at the commentaries that come to this article. For instance, a person called Todd Fox, a cancer survivor, he says, this is a subject on which, unfortunately, I know too much. His cancer was diagnosed by the CT, but now he has to undergo every 4 months another PET CT, and he thinks enough is enough. But the CT doctor in San Diego says this article is sensationalist and sloppy. A lot of people reacted very angrily to this article. Mike, a radiologist in Florida, on the other hand, says, allow radiologists to be the gatekeepers of medical imaging. Lane, an ED physician in Michigan, never ordered a CT scan without examining a patient. And that was actually one of the claims that this article made. And some ED physicians take this very personally, and they don't do it, of course. Stewart, a physician in New York City, complained about difficulty to get insurance approval for MRI scans instead of CT. And Nicole, a cancer survivor who had an appendix CT in her history, asked the authors to please reconsider the title of your article to avoid wrecking feelings of guilt over these CT scans in the past. So what do we know about the risk? It has been going in several lectures before. I will go quick about the different elements that go into our risk calculation, the lifespan study, atomic bomb study, where relative risk calculated, excess relative risk, which has a relationship to causation, probably, not for sure. Excess absolute risk, which is related to disease burden, the age of exposure effect, and the lifetime attributable risk calculation. So here's an example of excess relative risk for thyroid cancer, and anything that's over 0 is statistically significant. So we have the lifespan study, and we have the pooled data from many studies together, and this is a very creditable source from Dr. Ron in this article. And this is excess relative risk for solid cancer related to colon dose from the lifespan study. And it gets a little murky at the low dose spectrum here, so that's where the discussions come in. There's a background incidence, there's a background dose, and you have the linear, no threshold, you have the superlinear, you have the threshold, and the hormetic response. We all gone over this before. The time of exposure is important. A 1-year-old child has a chance of 1 in 700 according to the Bio-2 levels. A 5-year-old is a 1 in 1,000, and a 40-year-old in 1 in 2,000. This is all an extrapolation from the linear no threshold. We know this. I've been trying to look up the original publications. They're very difficult to read, both from the Bio-7 report and the Blue Book that is supposed to be digesting this better, the ICRP reports, and then finally the UNSCEAR report of 2013 that came out at the end of last year. Again, this hit the media with a claim that radiation can pose bigger cancer risk for children, but it's not really a study. The UN didn't do a study. It's just a summary of all of the literature that is available, and I recommend you all to look this up. It's downloadable. And it really summarizes all of the information that we know from stochastic, deterministic, genetic, internal and external, specifically tailored to children. Discusses differences in anatomy, physiology, dosimetry, biological effects in children, and differentiate sensitivity according to tumor type. So it's not true that all children are 9 times as sensitive. It depends on the tumor, as was mentioned in the previous presentation. It includes graphs like this and very good material, but I always find it difficult to understand and how to translate this into conversations with individual parents and patients itself. This is an easier table to understand because it shows that the amount of years that children can lose from a potential cancer induction is always higher as the child is younger. So these are the 2 most important articles that came out, and they were reviewed in previous presentations. I shall be quick about it. The Pierce article in Lancet, in the United Kingdom, they were exposed to CT over 1985 to 2002 and followed until 2008. They found excess leukemias, and these are statistically significant results. Also, they say that 1 excess leukemia and 1 excess brain tumor was found in 10 years after HX exposure, less than 10 years. UNSCEAR reports, and Dr. Cohen, Mervyn Cohen, criticized some of this, but it doesn't leave alone the fact that this is a real study that shows the results of people who are exposed to CT children and what the outcomes could be. So this is a very important article to consider. and not easy to put aside. The Matthews article, similar, we went over it before. Again, statistically significant increases in the number of tumors. But then there's criticism from the Unskier report that there is a lack of individual dosimetry and info about indications, or there's a potential for reverse causation. They started looking at the cancers perhaps a little too early, and also the statistical results were incompatible with the LifeScan study. They were actually higher than in the LifeScan study. They also found brain tumors in people who underwent body radiation, which is hard to understand according to biology, and also a lesser excess relative risk the longer you look, which is also implausible. Nonetheless, these are important studies, and we know that the power to show causation depends on, you have to examine millions and millions of people, and as the doses are going down, this will be more and more difficult to do a study like this. But the studies are on the way. The UK study I mentioned, the Australian study, and then the pooled data from many European countries, which is over 1 million. Results are expected in 2016. So we should look out for that and see what information it gives us. Paul Gilliman already mentioned that some children have an increased genetic susceptibility for cancer, and it's important to look at those that have an impaired DNA repair mechanism. So it is, again, it's individualized risk calculation. There's no one-size-fits-all, and when we know that we're dealing with one of those patients, we want to be extra cautious. And if you type in radiation risk in children, you get all kinds of interesting websites, and you get references to other areas as well. This is about Fukushima, the World Network for Saving Children from Radiation, and it is opinion. It's opinion. There's some websites that are showing this, that's showing them new studies. For instance, there's a paper that came recently out from the Chernobyl cleanup workers that found an excess risk of leukemia in exposures of as little as 5 milligrams to the bone marrow. And then there's this interesting paper from Kendall in leukemia, where they actually correlated leukemia incidence in the United Kingdom matched with controls, related to residential background radiation. So they found that 15% of the naturally incident leukemia was attributable to the natural background radiation. So we used to compare to the background radiation as being innocent, but if you believe this article, maybe that's not appropriate anymore. There's also increased thyroid abnormalities, including excess cancers from Fukushima. Ultrasound screening of children is being recorded as we speak. And then there's radiobiologists have looked at Chernobyl and even Fukushima, and they have found albinism and tumors in birds, mutations in worms. Does that have to bother us? I don't know. It's an interesting group of authors who have published quite recently about radiobiology effects in species that propagate very quickly, so it will propagate very fast. And you see the results faster than you would see in a human study. And there's counter-arguments from the scientists for accurate radiation information. There's always going to be difference in opinion. Now, how can we digest this and present it to individual patients? First of all, how can we estimate the scan of the risk here? And there's a lot of uncertainties, as been discussed before. But we have to start with converting the CTDI to the SSDE, estimate the original organ doses rather than working with effective dose, summate them over the primary beam exposure, as has been elegantly demonstrated by the group of Same and Frush, and then try to come up with a risk estimate if possible. Whom do we communicate with once we have that? Individual patients and parents. Karen Frush has thought it very eloquently how we can attempt to do that. Referring physicians. We should be interacting with them about this issue. Group. We can talk to physicians at conference. I had the opportunity to give a lecture sponsored by Image Gently to a group of physician assistants who would ask me all kinds of interesting questions. They are often the ones who are ordering CT scans, physician assistants and nurse practitioners, I found. And they were very educated about it, but they don't have a medical degree. They probably don't see the big picture. We interact with the media by sometimes being invited in a press conference or a quotation. You have to be careful with that. And then the public, the Image Gently campaign is doing that with the website, the FDA, the RSNA, as Marilyn has already summarized for us. Social networking and use of the media. This is the radiation page from the Mass General Hospital with links, and it's all very helpful. But then whose job is it to finally does this communication of risk if we want to do that at all? Is it the job of the referring physician? We are at the receiving end, so we can't do much about the risk and about the scan indication. Now, initially, the papers came out that said there was a very low awareness of parents about risks of CT radiation. But as the years moved on, we see that more people have become aware, and many discuss it in this VA setting with their primary care physician, and 17% of adults actually share the decision. Radiologists, should we be involved in this actively? We have a paper from David Larson about distributing a flyer in the outpatient department. There was still a low awareness amongst the public, but it didn't lead to any canceled CT scans. So he concluded it's okay to tell them because there was no cancellation. Another article where most of the referring physicians said that informed consent should be taken and that the radiologist should be doing it because we are getting the revenue from these scans. And that's what most people said we should do. And I don't know if that's appropriate in all cases. And then from the British studies where they do justification and audit, they are the gatekeepers. It's a different healthcare system. There's this study from sick kids where they did a survey with a fact sheet. Before head injury CT, there was a higher rate of awareness now amongst the attendees of the emergency room. 90% want to be informed, and 6% would refuse. And is it necessarily such a bad thing that some patient would refuse a CT scan? As long as there's a dialogue going on, and some people are willing to take their child home with accepting a risk, then it may be a good thing, not necessarily a bad thing, that some CT scans would be refused, as long as we do it in a thoughtful manner. And then finally, these risk communications will fall down to the technologists. I suspect most of them, the technologists are the ones who are dealing with the general public, and that's why it's so important to have educational materials out here, as has been shown by Marilyn Gotsky and others, for the technologists specifically, because they're the ones who interact and have to answer the questions and come up with thoughtful answers. So how do we do this? Your risk equals 16% of that a radiation worker, 400 chest X-rays, 42 months of background radiation. There's something missing from this phrase, and that is the dreaded C word. Nobody wants to use that word, cancer. It's the skeleton in the closet. We heard other paraphrases as well. Gorilla in the room, whatever you want to call it. And so patients may refuse life-saving scans if they hear that word cancer, and that is a problem. But then it's okay to tell them if they don't do anything, if they don't cancel their scans, is what David Larson has told us. Think like a surgeon. We are radiation workers. We know what we're doing. And just like the scalpel can harm people, radiation may harm people, and we just have to do a balanced discussion. So when do we do the risk communication? What is the best moment? Prior to the scan, elective by providing materials in the waiting room. It's very effective. Having a number available so that radiologists or others can answer questions, address them. In the emergency settings, it's probably not that appropriate to provide a consent form the moment the patient goes into the CT scanner, and that is probably not appropriate. But it is possible to do it, as a study from sick kids in Toronto has shown, to provide some information at least. And then in the so-called poorly indicated studies for pectus excavatus, for instance, just to get insurance, authorization for minor plastic surgery report, procedure. These studies can be done with MRI on radiograph just as well. And in children with non-specific abdominal pain, there may be a better reason to provide some better risk communication. After the scan, when patients come back with buyer's remorse, we have these number of CT scans, we're really worried about it. It's better to reassure them rather than emphasize the risk. And following an overexposure, and this is the event in California where you see this red beam of overexposure. The child got 151 scans and had this high exposure. The cytogeneticist found substantial chromosomal damage and this prediction of 40% lifetime attributable risk for fatal cancer and cataract. Probably not because it was just missed by the beam. So the lawyer came out with this statement. The problem in this case is that the parents are subjected to worry for the rest of their life. They're always going to have to worry for years, forever, because every time the child sniffles, they instantly start thinking about maybe this is the start of something really bad. And that is, I think, summarizes the problems that we're dealing with risk communication. So this was settled by a legal settlement for the hospital for an unknown amount of dollars. And the hospital had to pay a fine, which was actually contested, and the workers in that hospital have to undergo ALERA training. But there's these lawyers' pages out there that show these scary images of bands of hair that are missing, and all it does is scare the general public. How can we use the cumulative dose in a rational manner? Do we use effective dose or organ dose? I think organ dose is the way to go, as we heard in this meeting. But we have to be careful not to fall victim to the sunk cost bias. That is, every risk that was in the past cannot be undone. The frequent flyers to our hospital, they have a lower life expectancy, has been shown by these studies. Chronic diseases, Crohn's, cystic fibrosis, they have a higher risk of dying from their primary disease, malignant disease as well. And this has been very well summarized in the literature. But benign diseases such as appendicitis and stones, they compromise the majority of these sporadic scans that are performed. So if you feel your role as a public health advocate, it's probably best to focus on these sporadic scans that are done in healthy children to begin with. And then trauma. Trauma has been linked to future radiation-induced cancer risks that are considered negligible in traumatic brain injury, according to this recent publication. And this is the publication of Salibi. They examined 195 patients with traumatic brain injury, serious traumatic brain injury. 128 of them died, so they could only study 67 of them. And they estimated the cumulative dose from all these CT scans following their major trauma. It was not their own doses that they had in their hospital. It was estimated from general estimates in the literature, which is a flaw of this study, I think. They calculated this common figure that comes up all the time, 0.8%, and they then added this up to the baseline incidence of cancer and concluded that this risk is negligible. But realize these are all healthy patients. They have a serious trauma, and when they come out of it, hopefully, they're going to be healthy again. They don't have primarily a higher risk of cancer to begin with. So the mortality rates are lower, about 50% of the incidence rates, but they compare that with the rate of death from traumatic brain injury, which is so much higher than the cancer mortality. And then finally, they concluded that for every 285 patients with severe traumatic brain injury undergoing the necessary CT studies, one patient may die decades later, and they conclude as negligible. But who tells me that all of these 20, on average, CT scans after a major trauma are all necessary? Another thing is another flaw of the study. It's all how you frame the information. You frame it as a positive or a negative. You frame it as a small cancer risk or a small addition to a bigger general risk. I want to share with you this case history of Jessica, who is a 15-year-old girl with cystinosis. She has vague flank pain. Mother is very persistent, wants further testing. Each time she has another stone that goes down. And she had already 18 CT scans. Here they are, different techniques. And I added up all the doses and came to these numbers here, and calculated these risk factors according to the information I had available at that time. So here you see the CT scan, one of them, there's some stones, and they're already visible on the scanograms as well, as you can see. The patient has cystinosis and will develop more stones in the future. At that point, I decided to send an email to the referring urologist explaining the cumulative dose and estimated risk. And then after that, all the further follow-up scans were done with ultrasound. I didn't even get an angry response from the physician. I didn't step on anybody's tails as far as I know. So that put into question what was the indication to begin with to do a CT scan each time the patient has a renal colic. The patient, I spoke to her, she said, I reached my max and I can't have any more CT scans. So, is this a sunk cost bias that I became a victim to, or is it a rational limitation of CT use for benign disease? That's the question. How can we communicate effectively the dose? We have to mention an order of magnitude rather than a speculative number. We can explain these figures, 0.01%, 1 in 10,000, with a graphic much better than in these numbers. We compare them with a natural background radiation rather than number of chest X-rays. Makes more sense because chest X-rays are done for a reason. Background you cannot avoid. Compare with risk of everyday life. That is, I think, the most valuable strategy. Here in this British paper, which is more attributable to the British situation, they compare with days of background radiation, fatal cancer, and these diagrams here. Here another paper from the British literature that shows number of chest X-rays versus risk and correlating with various types of studies. I don't think this is very helpful, particularly not the iteration that came in the paper of Maloney, because they put in the higher sensitivity of children, and these lines are so steep that they don't convey a good message at all. The cancer is marked in red, and I don't think we should be using it. This is actually a more effective way. This is the one risk from cancer from a bone scan, 4 millisievert in a 10-year-old. This is the natural cancer incidence. So people can visually comprehend this much better than what we are used to. So anyway, how can we do informed consent? We compare it with the risk of an anaphylactic reaction, and we can compare it with a self-referred screening CT. People feel there's a need for informed consent. Diagnostic studies advocated in pediatric patients by a number of authors. Image gently takes the approach that we want to increase health literacy and shared informed decision-making. So, 20 cigarettes per day cuts 6 years of your life, overweight by 15%, 2 years, alcohol consumption, 1 year. These are all daily risks that we take every day. Natural hazards, nobody worries about background radiation. Occupational dose is very low, so only 15 days of our life cut as radiation workers. So then I did the converse calculation. 1 CT is equivalent to 140 cigarettes, 4,000 tablespoons of peanut butter. 200 years of living in New York City in 1979, these are all data with the air pollution. 4,000 miles of driving in a car, which nobody would think about. Flying by airplane, people worry about. Coast-to-coast flights, canoeing. These are risks that are taken by everyday life. A risk of 1 in 2,000 is perceived by the CT scan. It has to be compared with activities of daily life, smoking, driving, flying, living in Denver, having a normal appendix removed when you refuse a CT scan. That has a risk too. Or having the appendix perforated. There's a risk that you can attribute to that. 1 in a million, ignored. 1 in 100, occupational risk, unacceptable. 1 in 2,000 may be accepted if individual knew of the risk, shared decision, and received some benefit. So finally, how does that translate into patients' stories? This is the story of Angelina Jolie, who decided to have a bilateral breast amputation because of the BIC carrying. And so people read it, and there's been actually academic studies of how people processed all this information. And they showed that there was a poor public understanding of breast cancer risk following all these articles in the New York Times. And the general public cannot apply the knowledge to self and family. And some people actually, another starlet actually said that mastectomy was a fearful choice and not a brave choice. And the experts came out and said, when it comes to breast cancer, don't take Angelina Jolie's advice, because people tend to overestimate the risks of cancer. I'll go over this quickly and let's go to the end of this. Individualized risk communication, the bottom line is, informed decision-making trumps written informed consent. That is very important. We have to get into a dialogue with our patients rather than providing with a consent form. Consider the past exposures in some way, but don't fall prey to the sunk cost, and optimally based on absorbed dose estimate rather than absorbed dose, rather than effective dose. Present the benefit-risk equation, and I put the benefit before the risk here, and compare with risk in everyday life, and acknowledge individual differences in risk perception and tolerance amongst our patients.